Assalamu alaikum. The diagnosis of a superior laryngeal nerve paralysis is difficult. The symptoms are subtle, the physical findings are very few and may not appear at all in a routine ENT examination in a busy clinic, what looks like normal vocal fold adduction and abduction, and there will be no glottic gap. Yet there are now techniques for examination with specific laryngeal tasks and the use of stroboscopy and some basic voice lab for voice recordings. The diagnosis can be reached. The true prevalence of injuries to the superior laryngeal nerve, or more specifically the external branch of the superior laryngeal nerve, is unknown. The reported prevalence varies a lot, between 3% and up to 58% in one series. Many cases would go undiagnosed. It's difficult to detect the injury and its sequelae because of the subtle symptoms and the wide variability in the clinical signs and laryngoscopic features. It may be particularly noticed by patients who are professional voice users, where subtle changes can have a more noticeable effect on their voice and lifestyle. What would be expected if the cricothyroidus muscle is paralyzed? The cricothyroidus muscle is formed mainly of two bundles, the parus recta and the parus oblique, perhaps also with a contribution of a third bundle from the inner perichondrium of the thyroid cartilage. Activation of these muscle bundles with the excitation of the external branch of the superior laryngeal nerve would cause movement of the cricoid cartilage relative to the relatively more fixed thyroid cartilage. The cricoid would be displaced mainly posteriorly and also slightly higher position, and the arytenoid cartilage on top of the cricoid would be also displaced more posteriorly and slightly higher position. This would cause stretching of the vocal folds along its anteroposterior direction, but perhaps more importantly would cause a stiffening, increases in the stiffness of the vocal fold and also its tension in both the core layer and the cover layer of the vocal folds. This would be translated into changes in the fundamental frequency of the vocal fold vibration, because the changes in vocal fold stiffness is the prime adjusting factor for fundamental frequency of vocal fold vibrations. It is the cricothyroid muscle that causes most of the changes in the stiffness and the length of the vocal folds, with some contribution from the thyroarytenoidus muscle, and changes in the vocal fold stiffness, the limitation of the stiffness and the tension in the paralyzed muscle would cause the vocal fold vibration problems and consequently the changes in the vocal signal. The external branch of the superior laryngeal nerve does not only activate the cricothyroid muscle. There is now good evidence that the external branch of the superior laryngeal nerve can also contribute in the activation of the vocalis muscle, the thyroarytenoid muscle, through either direct innervation of the anterior fibers of the muscle or indirectly by communicating branch with the recurrent laryngeal nerve. This communicating branch is called human communicating nerve, which is found in just less than half of the cases. This has obvious clinical implications. It was known for a while that activation of the cricothyroid muscle through activation of the external branch of the superior laryngeal nerve can also activate the thyroarytenoid muscle, and this was registered by nerve monitoring intraoperatively by electrodes placed around the endotracheal tubes. What may cause a paralysis of the superior laryngeal nerve? By far the most common cause is iatrogenic, and by far the most common iatrogenic cause is thyroid surgery, followed by carotid endarterectomy, cervical laminectomy, radical neck dissection, and rarely things like cricopharyngeal myotomy or supraglottic laryngectomy or medialization, laryngoplasty, or even arytenoid abduction surgery. So it's generally neck surgery primed by the thyroid surgery. Neck trauma can cause injury as well, like whiplash injury, and other causes of polyneuritis like herpes simplex virus, Lyme disease, sarcoidosis, and diphtheria are some of the reported causes. And sometimes it can be idiopathic, and this group of idiopathic and viral causes still represent a large portion of the patient with unexplained paralysis or paresis of the superior laryngeal nerve. The symptoms are subtle, in fact very subtle. Some patients would present with just coughing or a globus-like sensation in the throat. Professional voice users may notice a slight voice change. It's not uncommon to describe vocal fatigue and some lowering of the speaking pitch. And professional voice users would also describe diplophonia when attempting to reach higher notes and a decreased range of the pitch. This is noticeable in singing, but also would give monotony of voice. And if the sensory branch of the superior laryngeal nerve is affected as well, then you may have some pooling of saliva and secretions in the hypopharynx and coughing and gagging, and this can help in aspiration in addition to the other difficulties in swallowing. Are the commonest voice symptoms for these patients? The commonest symptom will be voice fatigue, described by just less than 3/4 of the patient after a month of the thyroid surgery, followed by difficulty with the singing voice and difficulty with high pitch in about 2/3 of the patient, followed by difficulty with loud voice in just less than half of the patients, and very rarely these patients would describe hoarseness of voice. Notice that with time, all these symptoms would tend to be controlled with the compensation by the other internal laryngeal muscles. Just a routine and a quick laryngeal examination for patients who have thyroid surgery to assess whether the superior laryngeal nerve was injured or not may not be enough, because there will be wide variations in the laryngeal features for superior laryngeal nerve palsy. Such a wide variation is the cause for this. There is no general consensus about which features are diagnostic for the paralysis. The causes are multiple. Number one is the variability in the movement around the cricothyroid joint. There are two types of movement, posterior and oblique and superior displacement of the cricoid with the arytenoids on top. It is the horizontal displacement that really causes the stretching of the vocal fold along its anteroposterior direction and increases the fundamental frequency. If most of the horizontal displacement is preserved, then there will be no much features of palsy detected. The other is, when is this examination done? If it is done quite a few weeks or few days after the injury, there may be some attempts at compensation by the other intrinsic laryngeal muscles, including the thyroarytenoides and the lateral cricoarytenoid muscle. Both muscles can redistribute the tension along the vocal folds and also affect its length, and this would cause more variability in the laryngeal features. The third, which is perhaps more important, is which phonatory tasks are the patients asked to do during the examination. If it is just the routine examination with adduction and abduction, no specific features can be elicited. Some specific maneuvers would be required by the patient to do, including repetitive maneuvers in order to fatigue the paralyzed muscle before the diagnosis can be established. The physical findings are subtle, but we should be looking systematically for any signs of glottic axis rotation, like the posterior commissure rotating towards the paralyzed side, or a displacement of the petiole of the epiglottis in relation to the anterior commissure. Any signs of flaccidity of the suspected vocal fold paralysis, any signs that the affected chord may be a bit shortened or lies at a lower level compared to the other side, or a bit bowed. And then The testing by specific laryngeal tasks like rapid diadochokinesis. This is repeatedly doing to extreme abduction and adduction, for example, in succession, and repeating them long enough to notice any signs of fatigue, asking the patient to fully adduct by continuously saying E and then sniffing, or attempts at raising up the vocal pitch to the maximum, and this would excite one cricothyroid muscle, the contralateral, and you could be looking for any signs of excitation of the cricothyroid muscle on the affected side as well. And with use of stroboscopy, you'll be looking for any asymmetry in mucosal waves. And if there are reasons to suspect that the sensory part of the nerve is also affected, then you may notice some pooling of saliva in the hypopharynx or the laryngeal enteroides and some gagging. You will be also looking for the relative length of the aryepiglottic folds. If there is rotation of the laryngeal axis, one aryepiglottic fold will look much shorter than the other, and any signs of opening of the piriform fossa as well on the contralateral side due to this laryngeal axis rotation. It was also noted that due to this rotation of the posterior commissure towards the paralyzed side, that the ipsilateral aryepiglottic fold will appear shorter than the contralateral fold, and that the piriform sinus on the contralateral side would appear more open due to this rotation of the posterior commissure. Roy et al. Had experimentally induced temporary paralysis of the external branch of the superior laryngeal nerve by injecting a local anesthetic in some volunteers over the site of the nerve. And then he asked the patient to do some special phonatory tasks. When the patients are asked to do the glissando up maneuver, raising up their fundamental frequency, he had noticed that the posterior commissure would be rotated towards the paralyzed side, the anterior commissure would be rotating towards the contralateral side, and that the petiole of the epiglottis relative to the anterior commissure would be displaced towards the paralyzed side. Also, in raising up the fundamental frequency, he noted better adduction of the vocal folds. But more interestingly, when the patients were asked to do another phonatory task, alternating rapidly between maximum vocal fold abduction, like in, for example, during sniffing, and high-pitched phonation, saying E with a very high pitch, then he noticed that such a rotation is actually reversed, and in 50% of his subjects, the posterior commissure rotated towards the contralateral side and the anterior commissure rotated towards the ipsilateral side. Later, the same team confirmed the experimental findings in a report on patients' clinical cases who had partial or complete denervation of the cricothyroid muscle, and showed that the results are also validated in real-life situation. And these findings were confirmed by several other authors. In the case of external superior laryngeal nerve palsy, there will be almost normal abduction and adduction of the vocal folds, and during normal phonation with habitual fundamental frequency, there may be no much alteration in the position of the glottic chink in relative to the posterior commissure and the epiglottis petiole. But during special phonatory maneuvers, like a glissando up maneuver, a posterior commissure would rotate towards the paralyzed side, and the petiole of the epiglottis would rotate towards the paralyzed side in relation to the anterior commissure. Would possibly explain the dynamic rotation of the posterior commissure during phonation in the cases of superior laryngeal nerve palsy. Say it is the right side that is paralyzed, there will be only one active cricothyroid muscle on the left side. During normal phonation with habitual fundamental frequency, there will be no much activation of the cricothyroid muscle. The glottic configuration would almost be normal, with normal abduction and adduction and normal position of the glottic chink. However, when there is a need to raise up the fundamental frequency, the speech fundamental frequency, there would be activation of the unopposed left cricothyroid muscle. This is going to cause the rotation of the cricoid cartilage relative to the relatively more fixed thyroid cartilage. This anti-clockwise rotation of the cricoid would cause displacement of the posterior commissure towards the paralyzed side. The reverse would happen if the relatively more fixed thyroid cartilage would rotate in relation to the cricoid cartilage. Such a rotation, the clockwise rotation in this example, would cause the posterior commissure to rotate towards the contralateral side rather than the paralyzed side. This observation of sluggishness of the vocal fold on the paralyzed side in relation to the vocal fold on the normal side will become more evident after repeated phonatory tasks like the one described by Robin. The vocal fold on the normal side would be quicker to close up the glottis during adduction. There would be a relative lag, vocal fold lag, on the paralyzed side due to the external branch of the superior laryngeal nerve palsy. Robin proposed that the vocal fold hypomobility during fatiguing after these repetitive phonatory tasks could be diagnostic of the external branch palsy. Video stroboscopy will be required to report and register these very subtle changes. A video stroboscopy would show the phase difference between the two sides, with the paralyzed side being a little bit more sluggish in relation to the normal side. The normal side would lead the abduction and adduction of the glottal cycle, and the mucosal wave would appear earlier on the normal side than it is on the paralyzed side. And neck examination can sometimes be useful, palpating the neck for sensation of a cricothyroid muscle contraction during raising up of the voice pitch. If there is paresis of the cricothyroid muscle, it may not contract at all or may contract asymmetrically with a pitch glide. The other thing you can do is medial compression testing of the thyroid areas on the affected side. Usually this will improve the loudness and reduce the dysphonia. In addition, cranial nerve testing for the palate, the larynx, the tongue, and the hypopharynx should be done to check for the possibility of polyneuritis. Voice recording and analysis would also be useful. There would be usually excessive effort to speak without strain, and a lowering of the speaking fundamental frequency. Diplophonia may be noted, particularly on attempting to reach higher notes, and this is important, the decreased range of the fundamental frequency between the highest possible and the lowest possible, particularly when you're trying to sing. There will be loss of the loudness projection and inability to produce a falsetto. The most consistent effect on the voice in patients who had either external branch paralysis or external branch block experimentally would be this reduction in the range between the highest and the lowest obtainable frequency, and it would be consistent across the board while producing normal phonation with normal loudness. There would be a significant drop in the range, same while producing a soft voice and same while producing a loud voice, and also while trying the glissando up maneuver. On voice analysis, it would appear that the speech fundamental frequency would drop significantly in the patient who had paralysis of the external branch. There will be partial recovery after 6 months, but it's not going to return back to their preoperative levels. The other factor would be the range of the speech fundamental frequency between the minimum and the maximum possible speech fundamental frequency. Again, there would be a significant drop after the surgery, but it's going to recover gradually, but it may take as long as 6 months to come back to the preoperative levels. But the gold standard for establishing a diagnosis of external branch of superior laryngeal nerve paralysis remains the laryngeal electromyography. This is the most useful and precise method of establishing a diagnosis by detecting signs of denervation. It should be carried out in all medico-legal cases and should be considered before any attempts at restorative surgery for improving voice be considered. The applicability is, however, limited in the routine ENT practice because it's invasive and because it is technically difficult. It's also limited because the interpretation of the laryngeal electromyography traces are very much operator dependent. The EMG findings include decreased electrical activity on the cricothyroid muscle on activation compared to the contralateral normal side, or signs of fibrillation or positive sharp waves. These suggest denervation and are signs of superior laryngeal nerve dysfunction. The differential diagnoses include things like cricothyroid joint arthritis, prisbophonia, and myasthenia, either localized in the larynx or myasthenia gravis, and a paresis, not a paralysis of a recurrent laryngeal nerve, or functional dysphonia. And now to the treatment. Voice therapy seems a reasonable starting point because of the subtle symptoms and signs and the difficulty in establishing a solid diagnosis for superior laryngeal nerve palsy. The other point is that it is difficult even in established cases to restore exactly the function of the muscle, restore the dynamic action of the cricothyroid muscle when it is needed on raising up the vocal pitch, not during normal phonation, for example. So the starting point would be voice therapy. The voice therapy should focus on vocal hygiene and gentle stretching exercises, singing exercises designed to build up strength and prevent muscle tension and dysphasia. And therapy is targeting building up of the cricothyroid muscle strength using activities like glissando maneuver, for example. Recovery, however, may take a good few months. But if the voice therapy fails and there is no recovery in due course of the voice problems, then surgery may be considered. There are few options, none of which has a very large series. They are all relatively short series of patients, including elevation of the cricoid cartilage by attaching it to the thyroid muscle, or surgical approximation of the thyroid and the cricoid cartilages, thyrocricoid plication, or a medialization, Thyroplasty type 1, or selective cricothyroid muscle reinnervation using a muscle nerve to muscle cable graft. All these had been tried with various reported results. A successful outcome would be based on both either an improvement of the electromyography or objective voice analysis. One of the simplest operations are unilateral cricothyroid approximation by tying the cricoid cartilage ring to the inferior cornea of the thyroid cartilage, and this would mimic the action of the oblique part of the cricothyroid muscle. In a small series of patients, the reported results were excellent improvement in the quality of the voice and the vocal pitch range, but long-term follow-up showed that by different other authors that the improvement in the range would fail with time, possibly because of decreased tension in the suture line. The other option would be to do a type 1 thyroplasty in addition to the unilateral cricothyroid approximation. And the two procedures could be done at the same time. And this seems to offer a better outcome, and that the thyroplasty type 1 would increase the stiffness of the paralyzed vocal fold and allow for more efficient increase in the subglottic pressure. And this would lead to improvement in the voice quality and pitch range, and significant improvement in the symptoms, including the breathlessness and the poor pitch control and the vocal fatigue. Another option described was a nerve cable graft between the contralateral cricothyroid muscle and the ipsilateral cricothyroid. The graft would be buried in the belly of the innervated cricothyroid and the denervated one, on the hope that ultimately it would be taken. The graft would excite the denervated side on the activation of the normal side. The authors described good results with this technique, but there is a lot of room for failure when using cable grafts just buried into muscle bellies. By this, we come to the end of this presentation on vocal fold palsy, the superior laryngeal nerve paralysis. Assalamu alaikum.